All of you once again, and welcome to the teaching session of Department of Urology, Savai Man Singh Medical College, Jaipur. Today, we will deliberate on a topic which is very relevant, that is metastatic RCC, management of metastatic RCC. This is relevant, I said, because there has been a paradigm shift in the management of metastatic RCC in the last few years. And this is going to be presented by Dr. Satyaveer Singh, our resident, and this would be moderated by our faculty, senior faculty, Dr. Singh Yadav. So if Dr. Yadav has joined, kindly please moderate the session and invite the presenter, please.
Dr. Satyaveer? Hello.
Yes, sir.
Yes, I think you should start the presentation. Okay.
Yes, sir.
Yes, start your presentation.
Good morning to all our respected teachers, my seniors. Today I am going to present a seminar on management of metastatic renal cell carcinoma. About introduction, almost 1/3 of all renal cell carcinoma patients present with synchronous metastatic disease. Additional 20 to 40% of patients with clinically localized disease, they eventually develop metastasis. And metastatic renal cell carcinoma, it often fatal with 10 years survival rate less than 5%. Synchronous mets detected at presentation, they have worse outcome with many patients dying of disease progression within 1 year. The common site of metastasis, most common site is lung, followed by bone, lymph node, liver, adrenal gland, brain, and soft tissue. The incidence of metastasis after radical nephrectomy, it was stage dependent. The risk is greatest in first 3 post-op year. In stage first T2N0M0, the incidence is almost 7%. In stage second T2N0M0, incidence is almost 25%. And in stage third T3N0M0, the incidence of metastasis is almost 40%. Coming to the risk stratification, there are 2 criteria. One is MSKCC, that is Memorial Sloan Kettering Cancer Center, that is in patient treated with chemotherapy or immunotherapy. And another is IMDC, that is International Metastatic Renal Cell Carcinoma Database Consortium. That is mainly in patient treated with first-line vascular endothelial growth factor targeted therapy. About MSKCC criteria, the 5 adverse prognosis factors are carnoscopy performance score less than 80%, elevated lactic diadenosine enzyme greater than 1.5 times, low hemoglobin, that is less than 10 mg%, elevated corrected calcium, that is greater than 10 mg%, and absence of prior nephrectomy. On the basis of the presence of the prognostic factors, if there is no adverse prognostic factor, the risk group is classified as good, and the median overall survival is almost 20 months. And if there is 1 or 2 prognostic factor are present, the risk group is intermediate, and the median overall survival is 10 months. And if the prognostic factors are 3 to 5, the risk group is considered as poor, and median survival is almost 4 months. Coming to the IMDC criteria, there are 6 adverse prognostic factors. The carnoscopy performance score less than 80%, elevated corrected calcium, and low hemoglobin. Apart from this, there is neutrophilia, thrombocytosis, and less than 1 year from diagnosis to vascular endothelial growth factor targeted therapy. On the basis of this, if there is no adverse prognostic factor, the risk group is good, and median survival is almost 43 months. And if 1 or 2 adverse prognostic factor present, the risk group is intermediate, and median survival is 22 months. And if more than 3 adverse prognostic factors are present, the risk group is poor, and median survival is almost 7 to 8 months. It is a now clinical management of metastatic renal cell carcinoma. If they newly diagnosed metastatic RCC, consider for systemic, before the systemic therapy, we should consider cytokine nephrectomy or active surveillance. When we have decided to initiate a systemic therapy, or when we have seen that there is no contraindication to immune point check inhibitors, then according to histology, if clear cell histology and non-clear cell histology, on the basis of these IMDC risk group, favorable or unfavorable or intermediate or poor group, the certain drugs there should be started. That will be discussed later on. And in part of this, there is disease progression. Another newer drugs like cabozantinib, axitinib, they should be started. Coming to the management options, it may be a surgery, irradiation, cytokine therapy, and newer modalities, mostly in clear cell carcinoma, targeted strategy, immune-based strategies. Coming to the surgical management, there are mostly three surgeries: cytoreductive nephrectomy, metastectomy, and palliative nephrectomy. Cytoreductive nephrectomy or debulking surgery, it is local therapy. The rationale is that bulky tumors, they might inhibit key components of the immune system that is critical for combating cancer. Removal of this large bulk of the primary tumor, it may provide clinical benefit. The tumor nephrectomy or cytoreductive nephrectomy is curative only if tumor deposits, they all are excised. It includes patient with primary tumor in place and single or oligometastatic resectable disease. For most patients, cytoreductive nephrectomy is palliative and systemic treatment are necessary. Now, Carmina trial, it is a phase 3 non-inferiority randomized control trial. It investigates immediate cytoreductive nephrectomy followed by sunitinib versus sunitinib alone. It showed that sunitinib alone was not inferior to cytoreductive nephrectomy followed by sunitinib with regard to the overall survival. There was no significant differences in relapse rate and progression-free survival. Now, in the arm group of cytoreductive nephrectomy followed by sunitinib, the overall survival is 14 months almost, and sunitinib alone overall survival is 18 months. The best result they are seen with cytoreductive nephrectomy if there is low volume lung mets, a good performance history of the patient, and there is absence of atypical histology. Patient with IMDC or MSKCC poor risk criteria, if there are more than 4 risk factors are present, they do not benefit from the local therapy or cytoreductive nephrectomy. The resection of mets or metastastomy, the limited metastatic resection is improved disease-free survival, overall survival in some patients. It has been studied. A favorable outcome, it may be affected by the selection-wise, inherent difference in tumor biology and natural history of the tumor. Other confounding factors are also affect this outcome. The isolated pulmonary mets, that is the most common amenable to resection. Now, there is a curative or a complete resection. It is associated with a longer 5-year survival, that is 40% in curative resection versus 14% is only in incomplete resection. The favorable prognostic indicators, they are presence of solitary mets, age less than 60 years, disease-free interval if greater than 1 year. Another predictor of better outcome, they are with pulmonary mets, smaller tumor size almost 4 cm in metaclonus lesions. If there is liver or brain mets, it has poor prognosis despite complete resection, so surgery is generally not indicated. And radio frequency ablation, hyper intensity focused ultrasonography and radiotherapy, it is used. Palliative nephrectomy, indication for palliative nephrectomy are if there is injectable pain, patient is having hematuria, and there are severe paraneoplastic syndrome, we may go for palliative nephrectomy. Palliative resection of the metastasis, the indications are mainly solitary brain mets, metastasis in weight-bearing joints or bone, vertebral mets with impending cord compression, and this is usually combined with the radiation therapy or systemic therapy. Now, immunological basis for management of this advanced carcinoma, so they are interferon, interleukinins, immune check inhibitors like immunotherapy, targeted therapy, allogenic hematopoietic stem cell transplantation, and certain vaccine therapy. Coming to systemic therapy, it is immunotherapy. A common agent is interferon alpha. It is a group of protein. It has modest survival benefit. Response rate is almost 10 to 15%. Durable complete response rate is rare. It was earlier the systemic agent of choice, but after the advent of vascular endothelial growth factor pathway antagonist, it is no longer the systemic agent of choice. Interferon alpha, it should be start with 5 million international unit per meter square 3 times a week. The dose is escalated up to the 18 million international unit 3 times a week. It is given subcutaneously. Total duration is 12 weeks. In first week, 5 million doses given, but from 2 to 12 week full dose, almost 18 units it is given. The side effects of interferon alpha, they are pancytopenia, myalgia, arthalgia, flu-like lesion, illness, anorexia, nausea, vomiting, headache, diarrhea, and reversible alopecia. In interleukin therapy, the response rate in the range of 50 to 20%. The patient having receiving high dose bolus interleukin 2 regime, they have only complete response in less than 10%. High dose interleukin 2, it was approved previously by US FDA for metastatic kidney cancer. The dose is 6 lakh to 7.2 lakh per interleukin unit per kilogram every 8 hourly for 5 days as IV bolus. The total 4 cycle is given. In one cycle, there is 2 treatment sessions. So total 8 treatment sessions, and between 2 treatment sessions, there should be gap of 10 days. The mortality with interleukin 2, the mortality rate may also be observed at 2 to 5%. Therefore, careful patient selection, intensive monitoring, and early intervention with fluids, vasopressor, and antibiotics should be required. Coming to the toxicity, the vascular leak syndrome leading to hypotension, third space retention, and multi-organ damage, it has been observed with interleukin 2 therapy. Now, interleukin 2 with interferon alpha combination, the combination has higher response rate and higher 1-year event-free survival rate comparison to interleukin 2 alone. But there is no significant survival difference between the two, and the combination has higher toxicity profile also. The patient they might benefit with interleukin 2 therapy. They are mainly clear, they having clear cell histology, good performance status, solitary meds, lung meds, prior nephrectomy, and the duration of nephrectomy to systemic therapy is greater than 1 year, then they may be benefited. Finally, the availability of novel vascular endothelial growth factor and mTOR inhibitors. Because of this, a single agent interferon is no longer used as first line treatment of clear cell carcinoma. In certain selected patients, high dose interleukin 2 may be used. Now, targeted therapy, that is a molecular basis of this targeted therapy. If BHL complex, that is if there is BHL gene inactivation, the BHL complex it is disrupted, then it inactivates the HIF, hypoxia-inducible factor. The accumulation of HIF, it induces vascular endothelial growth factor, platelet-derived growth factor, and transforming growth factor alpha. And on the receptor, the various receptors that present on these growth factors, the drugs may act accordingly, and they may be used as a therapeutic agent. Now, European EU guideline for treatment of clear cell metastatic renal cell carcinoma. There is if there is a favorable risk factor, favorable risk group, the patient are considered favorable risk group, then standard of care or first line treatment is nivolumab and cabozantinib, maybe pembrolizumab or axitinib, or pembrolizumab or lenvatinib. Alternatively, sunitinib or pazopanib may be used. If IMDC criteria are the intermediate poor risk group patient, the standard of care or first line treatment is nivolumab, cabozantinib, pembrolizumab, axitinib, pembrolizumab, lenvatinib, nivolumab, ipilimumab. Alternatively, cabozantinib, sunitinib, and pazopanib may be used. Coming to the later line or second or third line therapy, if a patient had received prior immunotherapy, then standard of care is any vascular endothelial growth factor targeted therapy that has not been used previously while using with immunotherapy. And if patient has received a tyrosine kinase inhibitor therapy previously, then standard of care treatment would be nivolumab and cabozantinib. Alternatively, axitinib may be used. Coming to the one-by-one drug, bevacizumab, it is a humanized monoclonal antibody against vascular endothelial growth factor receptor A. The dose is 10 milligram per kilogram intravenously given every 2 weeks, weekly. It is well-tolerated drug. Side effects are hypertension, bleeding, fatigue, proteinuria. Response rate is almost 10%, and progression-free survival is almost 5 months. And the role of bevacizumab is not widely used as a single agent therapy for initial management because role is limited only in patients with vascular endothelial growth factor receptor antagonist therapy alone has failed. So in combination with interferon alpha, it may be used. Everon study, it is a double-blind study compared bevacizumab plus interferon with interferon monotherapy in metastatic renal cell carcinoma. Overall response was higher in the bevacizumab group comparative to interferon alpha group only. Response rate is 30%, and progression-free survival, that is 10.2 compared to 5 months in interferon alpha group only. In poor risk group patient, there is no benefit of this combination of bevacizumab and interferon. Overall survival, there is no improvement. Perhaps a combination is associated with increased toxicity also. Now, tyrosine kinase inhibitor, they are the sorafenib. First of all, is sorafenib. It is oral multi-kinase inhibitor against vascular epidermal growth factor receptor 2, platelet-derived growth factor receptor beta, and RF1. And dose is 400 milligram BD, 1 hour before or 2 hours after meal. The side effects are fatigue, rash, diarrhea, hypertension, hand-foot syndrome, thyroid disorder. They are highly likely of achieving tumor regression, 68%, but progression-free survival, it was similar to interferon alpha. Currently, it is infrequently used as a first-line setting. It's commonly used in patients whose disease progressed on sunitinib or similar drugs. Target study, it denotes the sorafenib versus placebo study. Overall survival is 7 months and 14 months. And sorafenib versus interferon. And now sorafenib is infrequently used as a first-line agent. The sorafenib, it is a dose is 400 milligram BD for 12 weeks. It is taken on empty stomach. 200 milligram 2 tablets. 2 tablets are taken approximately 5,000 to 6,000 monthly. Come to sunitinib. It is oral tyrosine kinase inhibitor against vascular epidermal growth factor receptor. Receptor beta and CK. Anti-tumor and is 50 milligram per day with or without on and 2 weeks off for a 6-week cycle. Overall response rate is 31% and progression-free survival, that is 11 months. The side effect of sunitinib, the diarrhea, dermatological manifestation is rash, hand-foot syndrome, asthenia, hypertension. They are the most common side effects. Other notable side effects, they are bone marrow suppression, hypothyroidism, and decline in left ventricular ejection fraction. Contraindication to sorafenib, that is uncontrolled hypertension, cardiovascular disease event in last 12 months, and brain metastasis. Coming to the sunitinib, the one cost is almost 47,000 1 month for 28 capsule, 4 week given BD. Review after 2 week, after 2 cycle of therapy, review, and if continue treatment, if the patient has a stable disease with clinical benefit, there is symptomatic improvement, or there is partial response or better response. Discontinue of drug if there is disease progression. The pre-treatment for pre-treatment assessment, CBC, RFT, LFT, cardiac history, thyroid function test, ECG should be done, and thyroid function test should be done after every 2 cycles. Sunitinib versus interferon alpha, a superior progression-free survival in combination. The overall response rate is 31%, better side effects profile and better quality of life. And sunitinib is widely used in first-line treatment of the metastatic renal cell carcinoma. However, recent studies demonstrate the superiority of programmed death factor 1 and programmed death ligand first checkpoint inhibitor based on the combination over sunitinib in the first-line setting, particularly in the patient with intermediate and poor prognosis renal cell carcinoma. Currently, sunitinib is largely used in the treatment of good prognostic patient or the patient who are unable to receive checkpoint inhibitor-based therapy. So, the immune checkpoint inhibitor, they are considered as first-line nowadays. Now, selective vascular endothelial growth factor receptor A antagonist. They selectively inhibit vascular endothelial growth factor receptor family. The advantages, they have less toxicity profile. The individual drug are pazopanib. It is oral angiogenesis inhibitor It has median progression-free survival of 11 months in treatment-naive population. It is considered as another first-line option. It has better toxicity profile than sunitinib. Dose is 800 milligram daily. Steroid as whole and caution in patient with hepatic impairment. Interaction with food also present. The compared study. Compared study is a non-inferiority trial between pazopanib and sunitinib. The overall survival is similar, but side effect is lower in pazopanib. The only side effect, significant side effect, that is raised transaminase in pazopanib. The PC's study that is that described between pazopanib and sunitinib trial is assessing treatment preference. It is randomized controlled double-blind trial. In this, pazopanib is preferred, while overall survival is 70%. Based on these factors, pazopanib is also a reasonable first-line option. The cost is 13,000 to 25,000 per month. With the advent of effective combination therapy containing immune checkpoint inhibitors, the role of single-agent pazopanib is limited, particularly in the first-line setting, largely to the good risk patient. In intermediate or poor risk patient, we should prefer immune checkpoint inhibitors. Now, coming to the axitinib, it is oral small molecule tyrosine kinase inhibitor. It has improved progression-free survival compared to sorafenib. In the AXIS trial, it was approved by the FDA for use in the second-line setting. The dose is 10 milligram per day, 5 milligram BD. The AXIS trial, it is the axitinib versus sorafenib trial. The patient who progressed with the first-line therapy, it means sunitinib, bevacizumab, temsirolimus, sirolimus, or cytokines. Then axitinib is used. The progression-free survival was 6.7 months versus sorafenib, that is 4 months only. Newer vascular endothelial growth factor receptor based targeted therapy. The cabozantinib is used. It is multi-tyrosine kinase inhibitor with activity against vascular epithelial growth factor receptor, MET and XL. It is a Metastatic. It is a phase 3 randomized study. It includes cabozantinib versus everolimus. It shows that higher response rate in cabozantinib and better overall survival, that is 24 months in cabozantinib group. The cost is almost 1 to 1.2 lakh per month. If a patient have the cabozantinib has adverse effect of fatigue, diarrhea, or palmar plantar erythrodysesthesia, the FDA expanded the approval of cabozantinib to include patients with untreated advanced renal cell carcinoma. Another newer drug is lenvatinib, that is a fibrous growth factor receptor inhibitor, and beta growth factor receptor alpha receptor also, BRCA receptor also. Approval of the combination of lenvatinib and everolimus in patient who had progressed on prior anti-angiogenesis therapy. Now coming to the mTOR inhibitors. mTOR, that is the mammalian target of rapamycin. It is a key intracellular protein with role in the several signaling cascades. It regulates hypoxia-inducible factor 1 alpha, translate instability, and its inhibitors block this hypoxia-inducible factor 1 alpha translation. So everolimus and temsirolimus, they are analog of sirolimus. They have demonstrable activity in renal cell carcinoma. The cell membrane tyrosine kinase inhibitor, they activate the phosphatidylcholinase third kinase, then activate to under the presence of the PTN gene. They activate ultimately mTOR, that is responsible for the gene expression, or then ultimately responsible for cell proliferation, cell survival, and angiogenesis. These mTOR inhibitor are inhibited by the mTOR receptor. They are inhibited by the everolimus and temsirolimus, and help in the cell lysis or inhibiting the growth of the cell, so helpful in cancer treatment. Temsirolimus, the dose is 25 mg given IV every week. Fairly well tolerated. Side effects are only mucositis, rash, hyperglycemia, hypercholesterolemia, hypophosphatemia, and pulmonary complications. It is US FDA approved drug and a reasonable first-line choice in the poor risk patients. It is not recommended for the patient with vascular epidemiology growth factor receptor or tyrosine kinase inhibitor refractory disease. Dose is a 25 milligram per ml intravenous once weekly. The single use vial. The cost is almost 40 to 50,000 per vial. Now, everolimus, it is oral mTOR inhibitor given 10 milligram OD, established in the management of the vascular epidermal growth factor refractory disease. It has superior progression-free survival for patient whose disease has progressed on sunitinib, sorafenib, or both, and so approved for the indication by US FDA. The cost is approximately 40,000 per month. Now coming to the immune checkpoint inhibitors. There are certain stimulatory and inhibitory processes that determine the nature and extent of the anti-tumor response. So the inhibitory receptor on immune cells, such as cytotoxic T lymphocyte, play a key role in the regulating the immune response. So anti-tumor response, they can be downregulated by activation of the T cell receptor, such as cytotoxic T lymphocyte associated antigen, and those mediating program cell death first. The T cell receptor and the program death ligand first. The certain drugs that are that acts on the that block program death first receptor, that is pembrolizumab and nivolumab, and the program death ligand first receptor are blocked by the atezolizumab, durvalumab, and avelumab. The cytotoxic T lymphocyte antigen 4 binding inhibits the T cell activation. They inhibit the T cell activation, and the blocking of this, they activate the T cell, so it causes the tumor cell lysis. The basis of cancer treatment. The ipilimumab, it is a monoclonal antibody targeting cytotoxic T lymphocyte antigen 4. A certain sort of side effect there are. Nivolumab, it is monoclonal antibody targeting program cell death first. It is so nivolumab, it is approved by FDA to treat patients with a metastatic renal cell carcinoma whose disease progress on an anti-angiogenic therapy or previously taken vascular endothelial growth factor receptor blocking therapy. So it is a regional option in that patient. Certain combination of the immune checkpoint inhibitors, they are nivolumab and ipilimumab. These are frontline treatment of patients with intermediate and poor risk clear cell carcinoma. It is a checkmate 214 trial. Another ongoing trial, that is combination of agent with program cell death first and vascular endothelial growth factor axis. That is Javelin study that considered avelumab plus axitinib versus sunitinib combination group. Now, allogenic hematopoietic stem cell transplant, the replacement of host or recipient immune and hematopoietic system with those of a healthy HLA compatible donor is the basis of this therapy. It has improved the survival rate. The adverse effects are pancytopenia, certain opportunistic infection, and graft versus host disease, having higher morbidity and mortality. But they are no longer being explored because there are better drugs that act on vascular endothelial growth factor receptor or immune checkpoint inhibitors. They are available, so it is no longer being explored so much. Other treatment options for clear cell carcinoma, they are chemotherapy. Generally, no role of chemotherapy in the renal cell carcinoma, but if there is sarcomatoid variant of RCC, then gemcitabine and doxorubicin based chemotherapy may be used. Hormonal therapy, there is no role for hormonal therapy, and systemic therapy for non-clear cell renal cell carcinoma. It constitutes about 15 to 25%. The vascular endothelial growth factor receptor factor inhibitors, sorafenib and sunitinib, the modest activity in the papillary renal cell carcinoma. Calcineutic carcinoma, chromophore carcinoma, other carcinoma, they is generally resistant to the systemic treatment. After trial, it is related to the everolimus and metastatic papillary renal cell carcinoma, showing modest activity of everolimus. Coming to the vaccination therapy, the aim of this therapy is because the renal cell carcinoma is immunogenic, so activate immune response against malignant cell by overcoming the tolerance triggered by the tumor. They effectively use the immune response against cancer. They used vaccine, the therapy that used in renal cell carcinoma, they may be categorized in the following categories. Autologous tumor cells. So derived from this, they are autologous tumor cell vaccine, dendritic cells, dendritic cell vaccine, genetically modified tumor cells, maybe genetically modified tumor cell vaccine, and protein and peptide derived vaccines. Example, Trovex and IMA 901. IMA 91 is the first vaccine therapy that made for renal cell carcinoma. It causes immune, the effect of this vaccine therapy may be studied in many trials that has been concluded that it prolongs overall survival, decreased tumor burden, and decrease in long-term cancer development. Vaccine, especially effective in the metastatic renal cell carcinoma patient, and they are more applied more in near future. So more clinical study and data are required to support this aspect of best treatment. Thank you for facing this.
Thank you, Dr. Satyaveer. Dr. Yadav, I would request Dr. Yadav to give his comments.
You covered a topic in a good manner, but I have some questions for you. Why we are not including number of metastasis and performance status of beside the performance status of the patient in the about deciding the risk stratification of the patient? Why? Type of the cells and number of metastases are very important, contributing about the targeted therapy.
Yes, Satyaveer, go ahead. So, Satyaveer, for the risk stratification, you have said that the Karnofsky score is important, right? So, in both the stratification, the Hanks model and the MSKCC model, Karnofsky score is there already. So, the performance status is definitely there in the risk stratification. Only the number of metastasis probably is not there, as in we do in a carcinoma prostate case. Here it is not used. So, any comment from anybody?
The number of metastasis or the site of metastasis, I think, would have a direct bearing on the performance status, I believe. So that's why they have not included the number of metastasis. If there would be extensive metastasis, it would translate directly into the performance status of the patient, the hemoglobin level, the LDH level. So I think that is one reason why they have not included the number of metastasis as a separate, prognostic or risk factor.
Yes. Okay.
Yeah.
This is our assumption, or this is in the fact?
Sir, it's not there in the. It's
No,
not
it is
there
not
in the
there,
criteria.
but
the IMDC criteria maybe nahi
but-
hai, and it's not there in the
नहीं,
Moderator criteria. दोनों में
नहीं, पर अभी recent जो articles है ना, they are giving the importance to the number of the metastasis very important. Number of the cells is very important, because if it is a collecting duct type of the tumor is there, these target therapy are not going to act. Therefore, they are giving the importance to the variant of the cells. If it is genetic modulated.
Most of the targeted therapies are basically indicated only for the clear cell variant, I think.
No, Neeraj,
no.
Except, yeah.
No, it is a cover. It was covered as a metastatic renal disease. So,
Yes, sir.
in the everyday collecting duct or other variant are there.
No.
This chemotherapy is good. Or it is, we are not covering only the clear cell carcinoma and metastasis.
No, Dr. Yadav is correct, because see, this is not included in the risk stratification, because diagnosing it as a clear or non-clear is definitely an important part of the whole management. So that has already been discussed, that clear cell carcinoma or non-clear cell carcinoma. So there is no dispute in that we should need to actually know exactly whether it is a clear cell carcinoma or a non-clear cell carcinoma. The prognostic factors would be different. So the prognostic factors, where the performance status, the LDH level, the hemoglobin level, the neutrophil, platelet, and whether there was a nephrectomy done or not, those are included in the prognostic factors. Only thing is, there may be a kind of a debate on the number of metastases, whether it should be included in the prognostic factor, because till now they have not included. Anyway, any question from anybody else?
I would like to ask Dr. Satyaveer.
Yes.
Why is sunitazine not given in brain met?
Pardon?
I would like to ask Dr. Satyaveer why sunitinib is not given in brain mets.
Yes, Satyaveer, please go ahead.
One of the contraindications that he said was that it should not be given in brain mets or it. So why is sunitinib given inside brain metastatic disease?
Does it? What, Satyaveer? What are the things that can probably indicate? So, do you know of a barrier existing? Okay. So I think here radiotherapy, the two important role of radiotherapy in metastatic RCC is number one, when there is a painful bone metastasis, and the number two is brain metastasis. So radiotherapy and the stereotactic surgery, radiosurgery is indicated for brain metastasis because the sunitinib and the other systemic therapy would not act, probably due to the blood-brain barrier. So anybody has any comment to make on this?
Yes, actually, sunitinib, sir, it is a large molecule. So that is why it's been found that it doesn't cross the blood-brain barrier. And now smaller molecular weight molecules are coming like lapitinib. And so that's why the response in brain mets, it's only very partial. So that's why for patients who have got brain mets, this does not work as compared to other parts of the body. So I think that Dr. Satyaveer, he should have known this because
yes,
it's a very commonly asked question inside the exams.
Yeah.
Also, one of the points is that if a person has developed brain mets in RCC, it anyway signifies a very poor prognosis, and the mean survival is almost less than 6 months. Liver mets and brain mets. And apart from the reasons that you mentioned that they don't cross the blood-brain barrier, so it is only for a symptomatic treatment that radiation, stereotactic radiation that is indicated.
Yeah. See, Neeraj, anyway, metastatic RCC, the median survival is low, still low, but definitely it has changed over the years with the molecular targeted therapy and ICI. So they say that this median survival has increased from less than 1 year to almost 4 years now. With metastatic RCC. So definitely these kind of treatment has radically changed the management of metastatic RCC. And anybody else has any comment to make or question?
Yes, sir. Yes, sir.
Go ahead.
So one of the things that Satyaveer didn't mention, or I think I overlooked it, maybe he mentioned in his slides, was that the treatment of metastatic RCC changed after, I think, 2015 or 2016 in a dramatic way. Before that, we were only giving, before that, we were giving only single agent sunitinib or sorafenib, or even before that, interferon. But after the 2016, I think there was, I don't exactly remember the name of the trial, when exitinib and pembro, the combination of, TKIs and immune checkpoint inhibitors was initiated. It was the keynote trial, if I am correct.
So is a checkmate?
Yeah.
So the first was the checkmate trial, and then the keynote trial. Yes, keynote trial had the combination of ICI and TKI. Yes.
And that completely changed the scenario of how we actually manage metastatic RCC. And they compared sunitinib with the combination of XZ and pembro. And they found that the complete response in the combination was almost 10 times higher than that as compared to sunitinib alone. And I think he should have put up a slide comparing the results of these, these two drugs. And as of now, the first line treatment of metastatic RCC, the good risk metastatic RCC, is a combination of XZ and pembro. Sunitinib, I think we are still giving because of, I think, various factors, mainly the cost issues. Otherwise, the first line treatment is XZ pembro.
Yes, I agree with Neeraj. This was the keynote trial where the exitinib and pembro, and it still remains the first line treatment in favorable patients with clear cell carcinoma metastasis. So definitely you are, and I would request the residents to kindly remember these trials. These trials are very important, right? So one, how it changed the whole treatment of metastatic RCC, the keynote trial, the checkmate trial, the javelin trial, And one more important thing here is about the cytoreductive surgery. Previously, we used to think that always we have to do a cytoreductive surgery first and then followed by kind of a therapy, systemic therapy. But now the two trials, the Carmina trial and the Certine trial, these two trials have proved that cytoreductive surgery is not important or appropriate in every patient. So only very selected patients would require a cytoreductive surgery. Rest of these patients may be straight away started with systemic therapy. So these trials have really made a lot of difference in the management of metastatic RCC. Anybody else? So I would request Dr. Yadav to give his last comments, then I will just summarize the whole thing. Yes. Dr. Yadav, please. So what I think, Dr. Yadav is not there probably, yes? Okay, so for the benefit of the residents, I will just summarize the whole thing. In last four or 5 years, the metastatic RCC management has radically changed. We know RCC is the 12th most common cancer, and 1/3 of these RCC will present with synchronous metastasis, and a little less than 1/3 will present as metachronous metastasis. Then again, when these patients present as metastatic RCC, it's important to know the prognostic factors. And then according to these prognostic factors, we know there are two models. One is the Heng's model and the other is the MSKCC model. And according to this, we need to stratify these patients into poor risk, intermediate risk, and low risk cases. And the role of cytoreductive surgery is also important here. Not all cases would require cytoreductive surgery. Cytoreductive surgery would be done either as a therapeutic intent or a palliative intent. So in palliative intent, usually if there is a bleeding which is not being controlled, or there is pain, or there are paraneoplastic syndromes, which may require palliative nephrectomy. Metastatectomy has also a role. Then radiotherapy is used only in patients with painful bone metastasis and patients with brain metastasis. Rest of these patients would require a systemic therapy, and systemic therapy includes cytokine therapy, immunotherapy, the TK and the chemotherapy, and the molecular targeted therapies, and the ICI, that is the immune checkpoint inhibitor therapies, right? So I think metastatic RCC requires a multipodal, multidisciplinary approach. And the major challenge is probably, particularly in our country, would be the cost factor, the availability, and the affordability of the patient. So if these patients cannot afford the newer targeted therapy, then probably we need to stick to the TKIs, which would be the next line of option in these patients. So the good thing is that with the advent of this targeted therapy, the TKIs have the price has reduced drastically. So I think that's it. If anybody has any comment to make, last comment, otherwise we will wind up the session. Nachiket, Neeraj, anything?
Sir, okay, sir. I think that.
Okay, thank you. Thank you. Thank you all faculty members and residents, and have a good day.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
स्ट्राइक है क्या सर 2 घंटे के लिए सर?